Welcome to the presentation for Module 7. This presentation will discuss disorders of the adrenal glands, specifically Cushing's disease and Addison's disease. Just a review of the adrenal glands. The adrenal glands are two glands that sit atop the kidneys. Each gland contains two distinct structures, the adrenal cortex and the adrenal medulla. The functions are separate. The adrenal medulla is the inner portion, produces catecholamines. Because catecholamines play an important role in the autonomic nervous system, the adrenal medulla is considered a neuroendocrine structure, so it works along with the neurosystem. The adrenal cortex is a large outer layer. It has 3 zones or layers. The adrenal cortex secretes mineralocorticoids. The specific one called aldosterone. Aldosterone plays a part in the management of blood pressure. The adrenal cortex that secretes the mineralocorticoids are produced mainly there. Aldosterone is a major mineralocorticoid. It maintains extracellular fluid volume. It promotes sodium and water resorption and potassium excretion in the kidney tubules. So, in summary, it plays a huge role in fluid and electrolyte balance. Aldosterone secretion is regulated by the renin-angiotensin system, which you may have heard of before, maybe in anatomy and physiology. We'll talk about it a lot as we talk about blood pressure, because that is how we regulate blood pressure. And also, it's regulated by the adrenocorticotropic hormone. And if you may recall, that comes from, it's secreted up from the brain from another endocrine gland in the brain, which is the pituitary gland. It's secreted from the pituitary gland. The hormones secreted by the cortex are often called the adrenal steroids or the corticosteroids. So basically, when we give patients extra prednisone, which mimics the effectiveness of corticosteroids, the adrenal glands will sense that, and the pituitary will sense that, and they will stop producing as much because they have found that the body's circulating has enough steroids to help it. So it will stop producing as much. If a patient stops taking that outside source of the steroids immediately in like cold turkey, then it takes the adrenal cortex and the pituitary gland a day or so to detect that now they don't have that extra, and basically they have to play catch up. So that is the whole backstory as to why someone who's taking supplemental steroids such as prednisone should not stop taking them cold turkey. It has to do with the adrenal cortex and the pituitary gland producing hormones that are very similar to the corticosteroids. And we don't want to mess with that level and that balance of those steroids because they are there to help us protect ourselves. Mineralocorticoids are very important to life and important to maintaining health. So we have to make sure that we do not alter the balance of those, or it will cause a patient to be sick. This is just a visual reminder of where the adrenal glands sit on top of the kidneys, and just a cross section here to show you where the cortex and the medulla, what we're talking about. Addison's disease is the most common form of adrenal hypofunction. Addison's disease occurs when more than 90% of the adrenal gland is destroyed. Early diagnosis and adequate replacement therapy, the prognosis for adrenal hypofunction is good. Acute adrenal insufficiency or adrenal crisis, which we'll talk about in the next couple slides, is a medical emergency. Addison's disease is thought to be autoimmune in cause, and it can also result from hypopituitarism, which means that the pituitary is not secreting the hormone ACTH, corticotropic hormone, to stimulate the adrenals. This is also where you can kind of start connecting the dots. When we talk about abrupt withdrawal of long-term corticosteroid therapy, remember we always tell our patients not to stop taking a steroid such as prednisone cold turkey, that they have to be weaned off of it. That's because your adrenals and your pituitary gland, when someone is taking these steroids, which mimic the effectiveness of corticosteroids, as I explained in the last few slides about the stopping of the long-term corticosteroid therapy, and that's associated with the fact that glucocorticoids are produced by the adrenal cortex and are essential for life. The main glucocorticoid produced by the adrenal cortex is cortisol. Cortisol affects carbohydrate, protein, and fat metabolism. It affects the body's response to stress and emotional stability. So we don't want to alter that level. We want it to be maintained. Hopefully it can be maintained by a normal acting adrenal cortex or a normal pituitary. If it is not, then we need to make sure that we prepare the patient to have supplemental glucocorticoids because they are required for wellness. Addison's disease means that we do not have proper secretion of our adrenal cortex of the mineralocorticoids and the hormones that affect our blood pressure, fluid and electrolyte balance, carbohydrate, protein, and fat metabolism. So these are the signs and symptoms that the patient will present with. Production of adrenocorticosteroids may decrease as a result of inadequate secretion of the adrenocorticotropic hormone, dysfunction of the hypothalamic pituitary control mechanism, or direct dysfunction of adrenal gland tissue. Manifestations may develop gradually or quickly with stress. Insufficiency of adrenocorticosteroids causes problems through the loss of aldosterone and cortisol action. Impaired secretion of cortisol results in decreased glucogenesis, which means that the blood sugar levels are not monitored well or managed well. It leads to a hypoglycemia, which is listed here in the slide. Reduced aldosterone secretion causes potassium, sodium, and water imbalances. Potassium excretion is decreased, causing a high potassium level, which can be irritating to the cardiac muscle. The patient will have a low sodium level, and they will also have a low water level. So a patient with Addison's is going to have a high potassium, low sodium, low water. Patients with primary Addison's disease will have hyperpigmented coloring to their skin. This is due to because of the destruction of the melanocytes. This is just another slide to assist you as a visual in determining what a patient with Addison's disease, what their lab values would look like. Remember, they have the high potassium, low sodium. Plasma cortisol levels, of course, would be low because that's what Addison's disease is. They have a low cortisol level. Corticotropin levels may be high, and that's because the pituitary gland is sensing within the body that the cortisol levels are low, so it's producing the corticotropin hormone in order to try to get the kidneys to release cortisol. So that's why we might see a high corticotropin, low cortisol. Essentially, Addison's disease is a low cortisol level, so we will give them corticosteroid replacement with cortisone or hydrocortisone. Other drugs listed on your module outline is prednisone and fludrocortisone. These drugs can be used as supplements for cortisol levels for a patient with Addison's disease. In a patient with Addison's disease, it's important to educate them, especially if they're taking these supplements, that the dosages for these medications might change due to the stress that they're having in their life. Stressful situations may require increased cortisol levels, and that's what our adrenal glands typically are able to do. But in these patients, they don't have the ability to supplement their cortisol levels in stressful situations. So they might need to alter their dose a little bit. They might have to adjust it, especially in hot weather when sodium is lost because of excessive perspiration. And especially in times of extensive stress. And the reason they have to kind of know that and understand that is because they could put themselves into an Addison's crisis, which is an emergency situation associated with Addisons. And we'll talk about that in the next slide. But they also need to know that they cannot just stop taking this drug cold turkey, because they'll go into Addison's crisis. And they also need to know that they need to take it regularly, and they should not skip doses, and they should just not stop taking it some days and then take it other days. And they may have to increase the dose at times due to certain situations or certain stressful situations in their life. So our job as nurses is to be able to educate the patient regarding their situation. We need to be able to monitor their fluid and electrolyte balances, specifically for high levels of potassium, low levels of sodium. Both of these things could lead to a cardiac event. So we have to be very diligent to make sure we educate our patients and monitor them. If we find that they do have an elevated potassium or low sodium, we have to treat that appropriately per the orders of the physician. We also have to make sure that the patient understands their medication, and we need to educate them on the risk of possibly going into something called an Addison's crisis, which is a life-threatening event. Addison's crisis is a life-threatening situation where there is an acute adrenal insufficiency. Remember what your adrenal glands do. They secrete mineralocorticoids, which are aldosterone, and glucocorticoids, which aldosterone regulates our fluid and electrolyte balance, and cortisol, glucocorticoids, help our body deal with stress. It regulates our fat and carbohydrate metabolism and helps our bodies in times of stress. So if we do not have these in sufficient amounts, our body will not be able to respond to this large stress on our stressful event, and the patient will go into an Addison's crisis. And that's where there is an acute need for cortisol and aldosterone supplied to them. Unless intervention is initiated promptly, however, sodium levels fall and potassium levels rise rapidly, and the patient could end in death. Severe hypotension results from the blood volume depletion that occurs with the loss of aldosterone. So the patient will have a low blood pressure, high potassium, low sodium level, which can be a life-threatening situation. This can occur due to a very acute stressful event in a patient's life. It can occur when someone stops taking their steroids cold turkey. That's why we always educate people not to do that. Even a person who does not have Addison's, if they are on high levels of steroids for long periods of time, if they stop taking their steroids cold turkey, they could end up in an Addison's crisis, and that's due to the fact that their body has adjusted to the fact that they've had outside sources of corticosteroids, and so the body's kind of adjusted and stopped making its own. And so it takes the body a day or two to catch up when somebody stops taking steroids cold turkey. That's why they have to be weaned off of them, or else a patient will be in Addison's crisis. Top teaching topics for a patient with Addison's disease is to explain that they'll need lifelong cortisone replacement therapy. Advise the patient about signs and symptoms of overdose or underdose of their medications, and that they might need to adjust in times of stress. Warn that infection, injury, or profuse sweating in hot weather may precipitate a crisis. Instruct the patient to always carry a medical identification card and to wear a bracelet stating the name and dosage of the steroids they take. Teach the patient how to give themselves a hydrocortisone injection in case that's their treatment of choice. Tell him to keep an emergency kit containing hydrocortisone maybe, and warn that they may need additional cortisone to prevent a crisis after a time of stress. All right, moving on to Cushing's syndrome. Cushing's syndrome is an umbrella term. It can mean the adrenal gland is oversecreting just one hormone or all adrenal hormones. Cushing's disease, that term is specifically, and that's what we'll talk about for this module 7. Cushing's disease is the excess secretion of cortisol from the adrenal cortex, and that's called hypercorticolism. It may be caused by either a problem of the adrenal cortex itself or a problem of the anterior pituitary gland or a problem in the hypothalamus. As we talked about with Addison's disease, glucocorticoids play a role in metabolism and the breakdown of fat and carbohydrates and the body's response to stress. So this patient often appears as the opposite as a patient with Addison's. These are some of the visuals of signs and symptoms, and this is due to excess cortisol levels. They have weight gain, muscle weakness, fatigue. The buffalo hump here is a pretty famous sign for Cushing's disease. The moon face as well. They appear as someone who has taken a lot of steroids is what they look like. So people who are on steroids as treatment, this is what they begin to look like. And that's due to the higher levels of cortisol. Lab tests and diagnostic tests for Cushing's disease, essentially, sometimes we'll do some imaging in order to determine if it's due to a pituitary tumor or adrenal tumor, which could be the cause of it. It also can, we can look at cortisol levels and ACTH levels to determine whether it's coming from the pituitary or if it's adrenal gland issue. Sometimes Cushing's disease, like I said before, can be a result of chronic steroid use. So that would be obtaining a patient's history and determining if they have been on steroids for another condition. Lab values for a patient with Cushing's disease is somewhat the opposite of a patient with Addison's, especially when it comes to the sodium level. They actually have an increased sodium level and they have an increased glucose level. If you recall, the patient with Addison's disease has a low glucose level and a low sodium level. So they're the opposite there. Treatment for Cushing's syndrome, Cushing's disease varies depending on the cause. If it is an adrenal tumor, then the tumor may have to be removed. They might have to have an adrenalectomy. If there's a tumor of the pituitary gland, that could require removal of the pituitary gland as well. There are some medications that can interfere with the adrenocorticotropic hormone or the production of the adrenal hormone. For this module, it is not listed on your module outline, but just so you're aware that that could be a potential treatment in the event that a patient can be managed non-surgically. Really, goals of treatment is patient safety, proper drug therapy, nutrition therapy, and monitoring for hypercortisolism and fluid overload can be a big problem in these patients, so we have to monitor for that. Nursing interventions are directed at nutrition therapy, monitoring INO, monitoring their weight, and then postoperative care if they happen to need an adrenalectomy or a pituitary removal. Nutrition therapy, make sure you understand that. That might involve fluid restriction or sodium restriction. Make sure the sodium levels are monitored closely and that we restrict in their diet. These are patients who might be on a no-salt diet, so we can manage their fluid and electrolyte balances. That could be something that would be appropriate for a patient in Cushing's disease. Monitor their I's and O's. Monitor for signs and symptoms of overload. That means edema, increased edema, puffiness, things like that. Low urine output would indicate that. Some patients might undergo radiation therapy if they have a tumor of their adrenal or a tumor of their pituitary, so make sure you review the care of a patient undergoing radiation therapy. We've talked about that pretty extensively. A patient getting an adrenalectomy are typically in the intensive care unit immediately after surgery, and if you can imagine, these patients are at risk for going into an Addison's crisis. So we have to make sure, because we just took their adrenal gland out, we are removing their ability to make corticosteroids, so we have to replace that, and we have to monitor them for going into an Addison's crisis. It's a priority intervention as a nurse taking care of a patient with an adrenalectomy. And remember, corticosteroids we have from our adrenal glands in order to help us protect us against stressors. Once we remove that, the patient is at risk for stressful situations, stressful medical diagnoses. GI bleeding is common in a patient with hypercortisolism. Cortisol inhibits the thick gel-like mucus that protects the stomach lining. So hypercortisolism can make the patient at risk for a GI bleed. Pathologic fractures can also occur. Remember, when someone is on long-term steroid treatment, that could put them at risk for osteoporosis. Same thing goes for a patient with Cushing's disease that has high levels of cortisol due to an adrenal gland problem. This concludes the presentation for Module 7 for Cushing and Addison's disease, adrenal gland dysfunctions. Just make sure you focus a lot on the patient's emergency situations that they're at risk for and patient teaching. This is a key for these patients. These are kind of rare disorders, however, teaching them proper care is a key to this. Please review the following questions and case studies in order to assess your learning. The answers to the questions are in your comment section. I encourage you to attempt to answer them on your own and then check yourself.